Today on The Future of Everything, the future of cancer diagnosis and treatment. Well, I don't think I even need to say that cancer is a terrible and scary disease, or really a set of diseases that affect many people worldwide. Loved ones, friends, and people themselves have to struggle. Very few people are not affected by this disease. And recently there's been great progress and generation of hope for improved diagnosis and treatment of cancer based on really progress in many areas. Improved imaging methods to take pictures and detect the cancer, ability to sequence the DNA of the cancer cells to understand exactly what's wrong and what might need to be fixed, better medications that are focused on specific defects in these cells to give a more focused treatment, improvements in radiation therapy, and many other areas. The U.S. government, the National Institutes of Health, has created a cancer moonshot, which is a large, well-funded research program to accelerate progress in cancer research in the development of treatments and diagnostics. Now, an important trend in cancer research is personalized medicine. And what do I mean by that? Well, can we use information about the individual patients to more sensitively detect the cancer in the first place? Can we use information about how the patient responds over time to choose the right sequence of treatments and combinations? Can we help the patient understand the likely outcomes of their treatment so they have less uncertainty? One of the big scary things about cancer is not just the diagnosis, but all the uncertainty that brings to the patient in terms of what does that mean for my health and my life? Am I talking months, years, decades? What's going on? Dr. Alizadeh is a professor of medicine and oncology at Stanford University. His lab has focused on understanding the biology of cancer, how it begins, grows, and how you can treat it from multiple perspectives, including the transition from normal cell to cancer cell, the role of the immune system, and the creation of new tools to study cancer. Ash, one area you have focused on recently is forecasting how a cancer will progress over time. Is it aggressive? Will it respond to treatment? How should we monitor it? How frequently should we monitor it? Why have you focused on this, and what could be the benefits to patients and their physicians?
Thank you, Russ. So in addition to the things you talked about, I happen to be an oncologist and take care of some of these folks, and in large part focusing on this problem's been motivated by the personal experience of looking in the patient's eyes and having a conversation with them as they go through this journey that you're going through with them. And it's really sobering to look at how blunt our tools are for getting a sense for whether you're making progress as you're going through the course of therapy. So the disease I take care of clinically is one of the most common blood cancers, aggressive lymphoma that we cure in the majority of patients, but it's not 100%. And in having a conversation with the patient about the likelihood of being in one of those, in the group that is cured as opposed to the group that isn't, is something that takes months, if not years, to determine. And
all that time, you and the patient are extremely worried.
Exactly. And so the thought was, we've historically in the past, looked at various time points during this journey and said, what information do we have, and how can that information help predict the future? But in part motivated by seeing how statisticians and other folks were making such forward progress using statistical tools to look at dynamic data, in particular in relation to elections, Nate Silver and some others, to take longitudinal data and build a framework for saying, who's going to win this election? Who's going to win this baseball match? Who's going to win this football game? Are you smarter as you integrate information over a time frame when you're looking at, let's say, a version of a film as opposed to still shots during during the transitions.
Now, certainly, I'm sure doctors and you yourself in your practice over the years have tried to do this. So what has changed that makes you optimistic that you can do an even better job?
Right. So, yeah, I had the same thoughts, but I don't think we have ever really done this in a longitudinally integrated statistical framework that makes an accurate forecast. And I think even in my own practice and in chatting with most of my peers, we almost treat the most recent data as the best data. So what's the score at halftime as a best predictor of the game, forgetting that maybe a quarterback's out, even though the score is tied. That
he was injured on the last play of the half.
Exactly. If you didn't watch the first half and you just tune in at halftime, you probably, in assuming that the score at halftime is more important than having watched the first half, you would be less likely to make a good prediction. And so we set out to answer this question. If you integrate the information over time using a couple statistical frameworks, do we do better? And I was surprised, actually, because I set out the guys to prove me wrong that the most recent information would be the best information. And it seems to be true that in integrating information dynamically, you make a much better forecast.
So how does this actually work?
Sure.
For real patients and real data, are they coming? I'm sure they're not coming to the hospital every day for a measurement, but there must be some sense of longitudinally following them, monitoring them.
So we've done this now for 3 types of cancers and are working on a bunch more, but we took the most common lymphoma, which is large B-cell lymphoma. That's the most common blood cancer. We also took the most common leukemia, chronic lymphocytic leukemia, and worked with a European cooperative group that had collected large numbers of patients and longitudinal measurements. And we took early stage breast cancer. And we said, okay, there are established still shots in the film that have been defined as predicting risk, stage of the disease, age of the patient, burden of disease, et cetera, and then still shots as the response. Did the patient drop or have the pathology clear, or et cetera? But now we are going to staple this information together in a statistical framework that says, okay, I'll either consider these things in isolation or I'll roll them up into an equation to give you a number, and that number will make the forecast, a calibrated probability.
So if I'm understanding, in the olden days,
Yes.
you might get 2 patients who they come to let's say it's their 2-year appointment,
Sure.
and they look identical. They have a similar blood test. They have similar imaging. You can't detect the disease, perhaps. And in those days, in the olden days, you might say these patients are essentially equivalent.
Exactly.
And then what I'm hearing you say now is the path by which they got to that point might actually make them have different expected futures.
That's right.
And so you might say, you two look the same, but I'm going to, well, to sound harsh, I'm going to give you good news and I'm going to give you bad news because the history of how you got here is very different.
Exactly. So this path dependence. So if you start in looking exactly the same way, you have the same risk factor, stage 2 disease, you're a certain age, and you get the same treatment, and one patient has a response, one doesn't, of course that information is different, and then you staple that information forward and you make a prediction, or you get to the same point that the score is tied, but you had prior histories.
Right.
So
this is The Future of Everything. I'm Russ Altman. I'm speaking with Dr. Ash Alizadeh about cancer and new ways to follow it and prognosticate about it. So is this a purely research result, or has it started to change practice, and in what ways?
Since the paper is published as a theoretical article, and I was surprised by how much excitement we've gotten from the community, our collaborators in Europe, and the broader community of American oncologists about trying to take this framework, and now that we've done it in several diseases, to use it for a predictive therapeutic change idea. We're still in the midst of designing a good clinical trial where we take the information and say, okay, now we're going to be changing treatment based on a number, not based on a
Feeling.
a feeling, or let's say an image,
Right.
say, right? A picture of here's this much disease I have. And that doesn't have a whole lot of history. So we've got to be careful about how to do that right so that we have the best chance of having the result mean something.
Were there surprising results in terms of, as you looked at this data, not only the current data, but all the past data, are there sources of data that were surprisingly more useful than expected or less useful than expected? Or did it actually play out mostly how you would expect in terms of what the most valuable pieces of information are?
I think I was surprised by how well the data complemented each other. I don't think I have a bias, of course. My lab has spent a lot of effort on trying to develop non-invasive diagnostics, liquid biopsies for helping make these movies, right, to get a sense of what's happening.
And for those who are not familiar, the liquid biopsies are samples of blood where you can detect the cancer.
The cancer.
And so it's much less invasive than a biopsy or a surgery.
Right. That's right. And if we measure these things, and these are, let's say, the DNA from a tumor that you can measure quickly after the start of treatment for a patient with chemotherapy. Within a few days of getting chemotherapy, these levels change so dramatically because the half-life or the lifespan of these DNA molecules is so short that you can see dramatic predictive power in and of themselves. And of course, us and many other groups have shown that those measurements are great at predicting the future. But it's the ability to use that information and what was there before, and also the additional information in the course of disease, radiographic data. We're not going to get rid of radiology anytime soon, and it does provide information. Let's say a procedure has a pathologist evaluate the result of neoadjuvant chemotherapy as before the surgeon does the definitive job of cutting out a tumor. We're not going to throw that information out. It has information in it. I think the thing I was surprised by was the complementarity more so than any one piece being the most important.
Yeah, that's actually good to hear that the oncology profession has chosen its tools relatively wisely, maybe not even realizing how wise it was. So I'm struck by this and thinking about it because a lot of it is forecasting the future, what the patient's state is going to be. How does it affect management? So maybe since many of us are not oncologists, how does knowing whether a patient has a relatively good prognosis or a relatively bad prognosis, how does that affect the way you treat them?
Right.
Do you give up sooner or do you get more aggressive?
Right.
Take us through how this information changes care.
Sure. So let's say we're talking about an aggressive lymphoma. So we're talking about just using, unlike, let's say, breast cancer or lung cancer, it's not a disease that the surgeons help us with, cut out as a way to cure the disease. We need to use drugs in combination. When a patient comes to see me, let's say like yesterday in my clinic, with a new diagnosis, we get a picture of where this disease is, what's the stage, what's the risk, et cetera, and you have a conversation with the patient. In general, you say, yep, we think we have a 60% chance of curing you with this regimen, and that's good information, but it's not a whole lot better than a coin flip, right? It's
I would go home nervous.
Right. You would go home nervous, and your oncologist is nervous, right? The whole team is nervous. You're fighting a battle together to save a life. And the question is, the things you're doing are toxic, they're expensive, and a human being's life is not a trivial thing to be playing a coin flip with.
Right.
So can you, through the course of this treatment, help, even if it's not for changing treatment, help set priorities, right? So do I prepare for my grandkid's wedding in a couple of years, or do I prioritize writing my will? Right? That's
harsh, but a
real situation. These are conversations I have regularly with patients. On the flip side, well, if this treatment is unlikely to work, could we imagine this strategy as a quick change of treatment? That's the experiment we need to do. But yep, this is chemotherapy. It works for 60% of patients to cure them. You're not one of those 60%. We should be putting you on a clinical study of a new drug. Let's say
I see.
these engineered immune cells, chimeric antigen receptor T cells, expensive but profoundly effective with a single dose, curing a large fraction of patients in whom the disease. Could we imagine doing such a thing? And we've been talking with a lot of folks about that kind of strategy.
This is The Future of Everything. I'm Russ Altman. I'm speaking with Dr. Ash Alizadeh about chemotherapy and the value of having better predictive information about what the future of a cancer looks like. So it sounds from your last answer that a lot of this is risk management, and knowing that it's an aggressive cancer might make you more willing to subject the patient to very harsh or even investigational therapies. But if the patient looks like they're going to likely respond well to the standard treatments for that cancer, then your level of risk taking might go down because you're pretty confident that the existing methods will be. Is that a fair summary of?
I think so. I think, in part, this disease is a poster child for oncologists because the lymphoma one, but the other ones are also relevant. I don't think it's about intensity as much as it's about honing the strategy based on the information. I could imagine for a significant fraction of patients, we give everybody 6 treatment cycles with a chemotherapy recipe. That's the recipe for the average patient, but not for the individual patient. Maybe you could get 1 treatment or 2 treatments and be done. So you could imagine this as lowering or de-escalating.
Gotcha.
On the flip side, it could help us pick drugs that are more effective than chemotherapy, but we can't ignore the history of 50 years of research to show that these recipes cure such a large fraction of patients.
So this is very exciting, obviously. And for the 3 diseases you mentioned, which presumably were in your first as you called it, the theoretical paper, it sounds to me like it would have general applicability. And I think you even made a reference to that. The community is excited about this, and it is now kind of part of the research agenda to see if this can work and be applied to numerous other cancers, prostate, you didn't mention, brain,
Yes.
et cetera.
Yeah, actually, it's funny you mentioned that. Prostate's the next one on the radar, and we've been working on. Brain tumors, we are also working on. The need for these things is data. So the theoretical framework needs data. So applying it to other tumor types and then doing the clinical studies to say, all right, risk management, but a therapeutic risk management. What's next for these folks?
This is The Future of Everything. I'm Russ Altman. More with Dr. Ash Alizadeh about oncology, the future of cancer diagnosis and treatment, next on SiriusXM Insight 121. Welcome back to The Future of Everything. I'm Russ Altman. I'm speaking with Dr. Ash Alizadeh about cancer and current trends in cancer diagnosis and treatment. So 2 things, and we made brief mention of this in the last segment, is this idea of a liquid biopsy. Biopsies are usually scary because it usually means a surgery, and liquid is just confusing. So could you take us a little bit more deliberately through this relatively new technology that we're hearing a lot about even in the popular press?
Sure. So you're right, and that liquid refers to a liquid that we're trying to sample, whether it's blood, whether it's urine, whether it's cerebrospinal fluid, et cetera. But by and large, most people have talked about blood. And in the blood, there are a variety of types of molecules or analytes that can give us some window into what the primary tumor looks like. These include maybe whole cells in intact form, circulating tumor cells.
So these are the cells that have broken off, and they're just sitting there in the blood.
That's right. So for blood cancers, that's not so unusual because they tend to circulate. But for solid tumors, we've known for some time that even in early stage tumors, some fraction of the cells get loose and circulate, and those are called circulating tumor cells.
So that's remarkable. Just to punctuate that means there might be some of my breast cancer cells, if I have breast cancer, in my circulating blood, so that you could take it from my arm.
That's right. That's one class. The other class is forget the cellular portion of blood. Let's look in the juice that floats on top of the blood cells when you spin the blood, and that plasma or serum, in large part folks have focused on plasma, has molecules in it that don't necessarily need to be in intact cells. They could have broken off. And one class of molecules that people have spent a lot of time on are called cell-free DNA molecules. It's fascinating because these molecules were recognized by a couple of French scientists in the 1940s before the Nobel Prize, before the structure of DNA was even solved, and that they recognized that these molecules were free and abundant in cell-free DNA, but not that abundant. It's still a needle in a haystack problem. So if one were to take that DNA and look for things that tell you something special about some part of the body, you can find and detect and forego a biopsy. So at Stanford, the work of Steve Quake and others has been transformative for medicine.
Are we thinking about using this to detect the cancer in the first place or to follow its progress as you treat or whatever?
So both of those are areas of active research. So the analogy I was mentioning to what Steve Quake has worked on is for figuring out whether pregnancy is associated with Down syndrome.
Yes.
And in the past, we used to use biochemical markers and ultrasound and so on, and being able to look for that's caused by an extra copy of a single chromosome, chromosome 21. But if you look for that in the blood of the mom, because by a few weeks of pregnancy, a few percent of the DNA is coming from the fetus, even though a few percent of the cells don't circulate, this makes it very easy to non-invasively, without putting a needle through the uterine wall,
the amniocentesis.
Get a look into this environment non-invasively. So that's a disease or a condition, I should say, where you have a whole chromosome and that you know what you're looking for. Cancer is much more heterogeneous, and the mutations happen all over all the chromosomes, and you can't take a single mutation and detect it. So that the liquid biopsy ideas are to look for mutations in DNA and help it inform you about early diagnosis, but also what mutations might be there that could help you inform a therapy, and then also monitor a response. Is there disease remaining or not, or is there things evolving?
This is The Future of Everything. I'm Russ Altman, and we're speaking about liquid biopsy and cancer diagnosis. So let me ask one. I know, as you know, I'm also a physician. One of the things that happens when we have these new capabilities is they allow us to look at diseases, in this case, much earlier than we might normally see the disease. And that means we often don't know what to do with the information.
Right.
So now that I can detect the cancer that's in the blood, perhaps before it has any clinical symptoms and before the normal way, I'm using scare quotes, the normal way to diagnosis, which is because of the onset of clinical symptoms or something, it becomes a little bit challenging to know what to do with this information, which actually leads me to the topic, which is that there's this immune system that I know there are theories that the immune system is actually doing some kind of surveillance and maybe helping us with very early cancers in terms of recognizing, getting rid of them before we ever have problems. So pulling back a little bit, can you tell me a little bit, because I also know this is another very hot area, about how our understanding of the immune system relates to cancer and new treatments for cancer?
Oh, sure. So the last decade has been a remarkable time for studying the immune system and its relationship to cancer. In fact, the most exciting drugs of the last decade have involved the immune system. So instead of directly attacking the tumor cells with drugs that kill the cancer cells, you now have drugs that engage the immune system to say, hey, wake up, and then the same drug working for many cancers has an effect in curing a substantial minority of patients who would otherwise be deceased of their
And obviously the immune system needs a little help,
right?
Because it's not doing it on its own.
That's right. And this imbalance that happens, we're still trying to understand all the rules of the system. What are the nuts and bolts that keep this system from doing its job the way that it was designed to? But we figured out a few of those, and to basically take the brakes that are put on the immune system by cancer cells and say, hey, this isn't right. We can get in the middle of this with an antibody.
So they're diabolical. I want to highlight what you just said. The cancer has figured out ways to get the immune system to calm down,
right,
arguably inappropriately,
right,
because there's been pressure on the cancer to do that so that it can grow and survive. So we need to stop, and you called them brakes, which is I love that analogy. So we have to figure out how to get the foot off the brake for the immune system.
Exactly. Now, how I think once liquid biopsies become good enough to detect cancers at an early time, that might afford us opportunities to leverage immunity. I don't think we are near that time in the next year or two. I think it's an emerging area. There are lots of folks that have been working on this problem to build tools that are sharp enough that you detect a significant fraction of early stage cancers. But there are versions of these things that I think could work towards it. For example, I don't know if you've heard of a test called Cologuard. Mm-hmm. This is you poop in the proverbial box instead of having a colonoscopy. And it finds a significant fraction of colon cancers that would otherwise have been missed because a large fraction of healthy adults who are eligible for colonoscopies aren't willing to have that.
So perhaps not a liquid biopsy, but another kind of.
Yes, I guess it depends on what state your bowels are in. But yes.
So this is exciting. What are the diseases that are looking like the most promising for these immune therapies? I'm sure there are people listening who themselves or their loved ones are struggling with cancer. Which are the cancers where these immune-based therapies are starting to appear, and what's on the horizon?
Sure. The earliest was a disease called melanoma, where chemotherapy and many other approaches had not been all that effective. And melanoma is the poster child for these kinds of therapies. Lung cancer has been the second.
So you're picking pretty bad cancers, I notice.
Picking pretty bad cancers and seeing this result, but a range of other cancer types now. In fact, these drugs are approved for half a dozen cancers broadly at various stages of the disease, but also in any cancer if it has certain molecular features, if the mutations look a certain way.
So this is happening now, and physicians in the community are aware of these drugs. And if you're lucky enough to have a cancer that's that's a terrible thing to say, but if your cancer does happen to be and look susceptible to these drugs, it's out there now.
Absolutely.
Very good. Thank you for listening to The Future of Everything. I'm Russ Altman. If you missed any of this episode, listen anytime on demand with the SiriusXM app.